So welcome everyone. My name is Mike Urquhart. I'm the Chief Operating Officer of Zoe Insights, and joining me here today is Dr. Gord McMorland, who's one of the partners at National Spine Care and Sports Medicine. Good afternoon, Gord.
Hey, Mike. Nice to see you.
So the genesis for this was really, I was having a bit of a pity party for myself at Gord's office a while back. I first hurt my back 41 years ago. I was in junior high school. I was doing a calf stretch up against the wall in the gym at HD Cartwright. My back went out. I went to the doctor and he gave me 5 days of bed rest. And I've had back issues ever since. And I've worked together with Gord now for more than a decade. And one of the struggles I was having was around the motivational piece around just doing all the things I know and Gord's taught me and other practitioners taught me I need to be doing. And he shared with me kind of the latest thinking around how to think about spine health in general. So after he said that to me, that was actually very, very powerful. And I thought it would be awesome to share that with a lot more people in a way that's easily accessible. So we set this up, and I really appreciate you taking the time, Gord, and everyone joining us. So Gord, could you share with people sort of what are kind of the latest thinkings around and spine health and how people should be thinking about their back and their neck, I guess?
Wow, could you ask a more open-ended question? Do you want to start like, kind of taking you through your journey, like when you were recommended 5 days of bed rest, did you say?
Yeah, and I think, but I think to start, maybe if you could share kind of the research coming out of Scandinavian countries around this idea of, and this was what was powerful to me. And we'll talk about a bit more of the flossing your spine, but how to really a different framework to think around around back health.
Yeah, so that was just like back pain obviously is a big deal. The World Health Organization identified it as in their big databases. They keep track of these things called the global burdens of disease, and the latest updates I think happened in 2019, and they, spine related pain and disability is considered the #1 cause of disability in the whole world. So some of the newer research coming out of Scandinavian countries has identified what they call low back pain trajectories. And it's just a robust bunch of research that has really reshaped our thinking on the natural history of back pain. We used to think of it in terms of like the common cold, where you'd get a bout of back pain and you do whatever to try and settle it out, and once it's gone, and then you just carry on. And now we recognize that that's not necessarily the case, that there's these different flavors of back pain, and it's part of our being upright and moving around. And we now think of it in terms of more a model like asthma or heart disease, cardiovascular health model of treatment as opposed to the common cold. So you'll have episodes where the back pain can flare up and you have your rescue plan. That might involve things that you need to be doing if your back pain has flared up, and you may need to seek certain kinds of treatment. And then you'll have episodes where your back pain is either completely gone away, or it might be a little bit of grumbly background noise. And your management strategy changes depending on what phase you're in. But you have to start thinking of it as more of a health management, health maintenance kind of approach, as opposed to just do something when your back is all screwed up. That's kind of the shift in thinking that's come out of the research in Scandinavia.
Yeah, and the thing I thought was particularly powerful when we were talking was, and sometimes I'm a bit slow, so I need simple analogies, and it was really just the whole idea of brushing your teeth, and the fact that every day, except for my kids when they were younger, pretty much everyone brushes their teeth in the morning and brushes their teeth at night, and we don't really think that that's a burdensome or unusual thing. Yet I was having a hard time sort of staying motivated on the idea of certain things had to be done related to my back. And so to me, it really helped to think about this idea of it. It's an ongoing journey. It's not an episodic thing. I should be just thinking about it as part of my life and something that I'm really thinking about every day.
Yeah, and fair enough. I guess the difference between a spine and teeth is you see your teeth every day in the mirror, whereas the spine's kind of behind you. You don't really see it. And so it's not top of mind unless it's sending signals that are getting in your way of carrying on your normal routine. And that's typically what we see in the clinic, right? Is a bunch of people wouldn't necessarily come to see me if they're feeling pretty darn good and they're kind of getting on with their life. They typically would come in if their back is getting in the way of them doing what they need to be doing.
Great. So on that note, can you talk a bit about active versus passive treatment and sort of the different approaches that are either the person being involved in their care or a provider like yourself?
Sure. Yeah, sure. Actually, this is a question I get a lot, and it's kind of a good way to put a different spin on it. I get asked a little bit, there's this urban myth. So I'm a chiro by training, and if you go see a chiropractor, that's it. You have to see one for the rest of your life and all of this stuff. And it scares people. But I guess passive care is essentially any kind of treatment that you wouldn't play an active role in. You basically go to some provider and they do something to you. So they, in my case, I would adjust your back or work on your muscles. If you went to see a physio, they might, do some needling. A massage therapist might massage you, or, you could get some modalities. A doctor might give you some medication. Those are all passive treatments, even surgery, injections, all of that kind of stuff. Whereas active care is something that you do, you play an active role in. And so that can be anything from understanding how to move properly, so when you go to pick something up off the floor or put on your shoes or roll over in bed, you do it in such a way that you don't strain your back. It could be, if you're in pain, here's some things you can do to relieve your pain. It can be how you set your workstation up and how you work at a computer. These are all active things. It can even go into exercises like core stability or hip mobility and all of these things. That's all active care.
And one of the things I found the most useful talking to you about recently, and then doing a bit of work after the fact, is this idea of the neutral spine, and just getting a feel for what a neutral spine feels like, and placing yourself with a neutral spine, and then thinking about that as I lift things, or as I kind of go through life. Can you talk a little bit more and explain to people what the neutral spine is?
Yeah, so sure. Yeah, great. Neutral spine is it's not a rigid position. It's more the natural resting position, I guess, of your spine. So if you're talking about the low back in particular, it has a normal curve to it called a lordosis, which means the convexity of the curve goes towards your stomach. And there's sort of a natural resting position it likes to be in. And that's generally what we call neutral position. And your spine is meant to move, so it's not meant to be held rigidly in a certain position. But the challenge with most back problems is the spine gets asked to get into ranges of motion that it's not really supposed to be in, or it gets taken into positions and held there for extended periods, and that just builds over time to create problems. And so we teach people where neutral is, and then we work on what's called the joint by joint model to make sure that people know how to move properly, so that the spine doesn't fall victim of having to compensate for other body parts that aren't doing their job properly. So a good example might be like if I speak to the joint by joint model, all that means is we're a series of linkages. And when we move, there's areas that are supposed to be stable and areas that are supposed to be mobile. So if I build you from the ground up, your feet are supposed to be stable, your ankles mobile, your knees stable, your hips mobile, your low back, like your core, is supposed to be stable, your mid back is supposed to be mobile. And so if you mess with that formula, you typically run into trouble. So one of the classic examples, and I think what you've run into trouble in the past, is your hips are supposed to be mobile, but yours aren't. They're too stable, they're too stiff, right? And so then in order to gain mobility, as you go to do stuff, if your hips can't move or your mid back can't move, then your body has to gain mobility in your low back. And that's fine in the short term, but in the long term, the repetitive strain of your back being asked to move more than it's designed to move builds up until finally the ligaments, like your discs or your SI joints or your facet joints or your muscles, finally, kind of give the time out that we can't do this anymore. And that's when you have an injury.
Yeah, and one of the most interesting things I've found over the years is I had a lot of injuries sort of in my teens from playing basketball with my ankle, and how that instability in my right ankle has over time created all sorts of issues up the right side of my body.
Yeah, I guess I don't know what your privacy issues are on a Zoom call,
I'm allowed to say whatever I want about myself.
Yeah, and am I allowed to detail that, or?
Sure.
Yeah, so
I consent to that.
yeah, 100%. That there's actually some pretty good research that happened right at U of C, where ankle instability creates this reflex that shuts down the ability for you to recruit your glutes very well. And so we know if your glutes aren't there for you, if they're weaker than they're supposed to be, it makes your back vulnerable. Your hips won't move properly, and then it overloads your low back. And so you end up with, sacroiliac joint problems. It can build over time to create disc problems. So if you get a bulge disc, you might get a bit of sciatica, all of these things, which I think you're kind of familiar with.
Yes.
Yeah. So yeah, the body moves as a unit. We think in terms of movement, not individual body parts. So definitely your recurring ankle sprains that you suffered when you were playing ball, sure, that can lead to back problems.
And what can people do to minimize the chance of experienced back pain or neck pain? What are some practical strategies around that? That's all, you just solve everyone's back problems right now. You got 15 minutes. Go.
Okay. Well, this is easy. Yeah, I think the main thing is basically breaking it down to figuring out what we call directional preference. So most back problems are the result of what we call a directional preference, and all that means is that there's certain movements or certain body positions that backs like, and then there's certain movements and certain body positions that backs don't like. In general, so this is credited to a really famous physio, Robin McKenzie, figured this out years and years ago. And in general, most backs do not like flexion, which is bending forward, basically. You can bend forward, but if you do activities that involve a lot of repetitive flexion, or put your body in flexion and hold it there for extended periods of time, the stress of that builds up until finally it becomes an injury. So good example is sitting, bending forward at the waist, especially if you're going to pick things up, all of that stuff. So I guess the first thing to answer your question is identifying if your back has a directional preference to it. So if I don't mind referencing back to you, Mike, you're a flexion intolerant back. I think you've learned the hard way that if you participate in activities that involve a ton of flexion, it'll build over time until finally you pay the price and your back blows up. So that would be the first strategy. Is if you are a flexion intolerant kind of person, then you start to have to figure out what is it you're doing all day long that's going to provoke your back, and start to come up with strategies to work around that. And so that would be minimizing or avoiding things that involve flexion, but in practical, uh, a lot of times your world it's not practical to avoid that altogether. So then you have to, if you have to do things that involve flexion, then you're going to have to build in routines that offset the stress and strain of that. And I think we were talking just before we jumped on this, how you've now recognized that you love to cycle and ride a bike, which is a flexion activity. So you either stop doing that because it provokes your back, but that's not practical. You want to do that. So then we had to develop a routine that you do to offset the stress and strain. And I think you were mentioning that as long as you are faithful to that and you don't fall off the wagon, then you do pretty well with it.
Yeah, yeah.
And then, there are treatments like everybody, that would probably be the number one. And that's an example of active care, which I'd really encourage people to get with the program. It's just unrealistic to get in with a practitioner such as myself and expect that if I see you for, let's call it 15 minutes once every week or two, or even once a month, and I adjust you and work on your muscles, that's going to offset the stress and strain of everything your life throws at your back all day long. I'm happy to do that. I'm happy to, check in with people and make sure they're doing well. But the lion's share of the management has to be in your court, where you figure out what keeps provoking your back and minimizing that, or creating workarounds that if you have to do it, these activities will allow you to do it more frequently.
And a great example of that, just sharing some of my personal history. So at different points in time, as Gord mentioned, I do enjoy cycling. I actually tried track cycling for a couple of years, and the extreme flexion of a track bike. In the end, I remember I actually went in to see Gord, and we had a heart-to-heart talk on my future in track cycling, which was there was none. And I think that's one of the biggest takeaways I've gotten, is that sometimes, you can do things to basically manage your back. So I continue to cycle. I probably ride my bike about 4 times a week. I have 6 bikes, so I have lots of different choices on what to ride with. But and I'm not giving that up, but I recognize that there's some work that goes along with that. I did actually have a very aggressive car at a point in time that called a Caterham Super 7 that I also had to go and have a chat with Gord about. And I actually sold the car as a result, because it put my back in a permanent state of flexion with essentially no real suspension. It was like a glorified street legal go-kart. And it turned out that was just a recipe for disaster for my back. So I think one of my main takeaways over the years has been, you're making choices in your life as to what you're exposing yourself to, and then you sort of deal with the consequences. And everyone has to decide for themselves how much time and effort they're gonna put into things. I chose not to keep that car because it would have taken me all day to keep my back happy. So that was something that had to go. But I'm not giving up riding, because I love riding, and so I've gotten into a good routine post ride and on days when I'm not riding that seems to keep my back happy.
I can't remember, was it the Caterham, or the Lotus, that the other safety issue was when you sat in it, like the windshield was right in your eye line?
That was my Lotus, yes.
Okay, because that was another safety concern I had.
My spine to go over a bump, and I sold that too.
Okay.
Thanks
Yeah,
for reminding me that, and rubbing that in. What about COVID-19? What have you seen coming out of COVID relating to back health and spine health?
Yeah. Wow. Probably the number one thing we're seeing is just crappy ergonomics. People working from home, they've got their laptop on the kitchen table. You know, so the postural strain, conversation, neck pain, headaches, back pain, you know, sciatica, numbness and tingling into the fingers. That's a real thing. The other one, you know, everybody's done the COVID-19 where they put on 15 or 20 pounds because they're fairly sedentary. Gyms are closed. You know, the workout classes are canceled. It's been a real grind that way. You know, but it's all not doom and gloom. I mean, on the positive, I think is just a ton of people have bought bikes or bought cross-country skis or are out on the pathways or in the provincial parks hiking. So, you know, there has been increased activity. Try and buy a bike these days and see how it goes.
Yeah. So the ergonomics piece really resonates with me because I do find now, between like working from home and being on a Zoom call like this, especially in my neck, and all the mousing I'm doing has really sort of created some issues. Talking about approaches to it, so one of the things I have done is I have a sit stand desk, and you know, I find that, you know, there are times when it's nice to be able to stand and work. And I can you I actually honestly can't remember. It was your partner at the clinic, Josep, who gave me recommendations on how long to stand and how long to sit, and my memory is good but short. So maybe if you could tell people what kind of the thinking is on sit stand and some of that stuff, and what they should be thinking of, because I know you're not supposed to be standing all the time and you're not supposed to be sitting all the time.
Yeah, it just gets back to your body's meant to move, right? And so anytime you make it be sedentary or don't move, you can run into trouble. So standing for prolonged periods without moving is just almost as bad as sitting. The only thing when you sit is you double the amount of pressure on your discs in your back, in your low back. So you hold them in a stretched position and then you increase the pressure on them, and over time that's not a good recipe. But I would say transitioning, certainly maximum of 1 hour. You'd want to say sit for an hour and then transition and stand for an hour. That would be a good guideline. If you follow strict, you know, biomechanics research, you got to do it every 15 to 20 minutes. But if you start giving advice like that, the practicality of that, then people's workflow is so disrupted, it just doesn't happen.
Right.
So every hour, get up and move around, or stand up and work, and then after an hour, sit down.
Okay. And why is it that as I've gotten older, there's a certain amount, there seems to be I'm less flexible, or there's more stiffness in my back, first thing in the morning. And this is something that I'm like, now I'm 54. It's one of those things I'm starting to notice more.
Do you make the old man noise when you get up? Is that what you're talking about?
I do the old man noise. Yes.
Yeah.
Yeah.
Yeah, that's just generally as we age, our tissues tend to, I guess, dry out, for lack of a better term. And it's kind of like the oil in your car, that your core temperature cools down overnight. And so your tissues have water in them. That tends to, you know, the gel, it gels up overnight if you cool it down. So as you get up in the morning, you need to get your core temperature back up before things loosen up. And so it is a real thing. As you get older, you're generally more stiff in the mornings. The rule of thumb is that stiffness should pretty much go away or be significantly better within, say, 30 minutes or an hour. And as long as, you know, you're feeling pretty good once you've been up moving around or taking a hot shower, within an hour, then you're fine. If it starts lasting longer than that, like if you're still pretty sore into the afternoon or whatnot, then you've probably got something that needs to be assessed.
And what is your thinking on when's the right time to seek treatment? So I know for me personally, I'll have certain amounts of pain and I'll try to deal with it with rolling and stretching and things like that. I think I've actually missed the mark at times when I should have come in sooner.
Mm.
What is kind of your thinking around if you have pain in your back, what are kind of milestones around when to seek some sort of passive treatment?
Um, yeah, there's so many different flavors of back pain. That's a tough one to answer. I guess there's one of the cautionary things I think people need to know about are what we call red flags, which is back pain because of a sinister cause. Something's going on that is not good, and you need to be assessed sooner rather than later. Thankfully, that's maybe only 1 or 2% of back problems, but these would be things like, I mean, the pain is intractable. You can barely move. Certainly, if pain is shooting down your leg or legs, that's a big deal that needs to be assessed sooner rather than later. Another red flag warning: if you lose control of your bowel or your bladder, you need to be assessed really quickly. If you've got unexplained weight loss or the pain's waking you up at night, you should be assessed. Those are all good guidelines to get in to see a healthcare provider sooner rather than later. Other than that, like if you're talking about, sort of what we call mechanical back pain that can build over time, if you have an episodic flare-up and it's not settling down, like I would say within 7 to 10 days, you should really seek attention. And some of the attention might do an assessment and say, no, you're doing all the right stuff. You just have to give it more time. You don't need formal treatment, but it's sort of one of those, you're better safe than sorry. I always think, why would you hesitate if you have access to good healthcare? Get assessed sooner rather than later. The advice you get might just be active care advice, meaning here's the things you can continue to do to help yourself, and it should run its course within a reasonable time frame. I don't know, does that help?
Yeah, and I think the other thing that I've learned over time, and I think that's a bit of an unfair question because it's very specific to the individual, but I sometimes make some bad choices with the way I lift and do other things. And,
Hmm.
the most recent example was I was running the chainsaw at the farm for a couple of days, bent over, and then my back hurt, big surprise. And then I tried to kind of manage it myself. And as a result, I had to get treatment. I had to get passive treatment for a couple of weeks because things had gone horribly wrong. Which has actually resulted in me both rethinking the way I seek treatment, but also the way I cut wood at the farm. And we're actually coming up with a back sparing approach to how we run the chainsaw. Um, it's 12:30. We had a few more questions on our list, and I'll use those if other people don't have questions. But anything as we finish off this part of our discussion, anything you wish I had asked that I haven't asked that you want to share with people, or should we just jump into the questions and see what is on people's minds?
Um, I guess just generally to speak towards uh, modern treatment methods or care planning around back problems. Like our shift, we've really shifted our thinking in how to try and help people that are experiencing back pain. Old school would be more what we call a structural diagnosis, and that was where you had pain and you'd go see somebody and they would try and diagnose where the pain is coming from. So is this a disc problem? Is this a facet joint problem? Is it a muscle problem? And the idea there was, if we could identify the thing or things that were generating your pain and just direct the treatment towards that, then, that would heal up and life becomes good again. The pain would go away and off you go, you're back to normal. And we've recognized now through years and years of historical research that that approach doesn't work very well. It might help up, maybe 20% of people that have back problems. So now sort of the new school thinking is we don't ignore the structural diagnosis. We still try and figure that out, but we also layer in what's called the functional diagnosis. And that's where, if you've got a recurring back problem, we start to look at the function of how your body moves. It kind of gets back to what you were talking about with your ankle and your hip. And so we start to try and ask the question, is your back a victim here, or is it the culprit? Meaning, is it the tissue or tissues that are getting strained that are the problem, or are they a victim of something else not pulling its weight? And if we only treat the back where the pain is coming from, but we don't address the functional problem that keeps overloading your back, then we're never going to get anywhere. And that's really the more modern approach. And that speaks to all the self-care things that we get you going on. The other thing that's really taken hold is modern pain science has now completely reshaped our thinking on how to interpret people's pain and how to think about it, because oftentimes we get presentations where somebody's pain does not match how much damage has gone on in their back. There's a disconnect there, and we have to understand why that is. And there's a bunch of very smart people, pain scientists, that have figured out how to best approach that as well. So we layer modern pain science treatments in with this functional approach to back problems, and hopefully the outcomes will be a lot better.
Okay, awesome.
Unless you're operating chainsaws in a bent over position, and then forget it. All bets are off.
Then get those log stands that my dad's building for me, so that I can
and hopefully the least of your concerns is your back problem.
Yeah, exactly. I do wear chainsaw pants and steel toe boots when I run the chainsaw, so safety first. That's my motto.
Nice.
So everyone, we're gonna end the interview here, and please start putting your questions into the question and answer section. If you have something, you have a specific person you want to address it to. I'm assuming most of them will be for Gord. If you have anything you want to know from me, feel free, just say Mike in the question, and then we'll start answering everyone's questions, and hopefully we can
I see one. Would we be willing to expand on what the pre and post bike ride management's like? Mike, do you want to speak to that, or we could tag team it?
Yeah, I'll give you what I'm doing, and then Gord can critique it. So pre is some pretty active warm-up stuff. So it's essentially, from a back perspective, it's kind of more the cat-cow type of thing to gently stretch my spine. So more of a yoga type of thing. Some stuff with my legs, like sort of kicking my legs forward and backwards, and then side to side. Because I pretend that I'm competitive, I don't want to do static stretching, because I understand that will decrease my performance, as if that makes any difference right now in my life. So it's really an active warm up. Then post cycling is to me the most important part. It's rolling. I have some issues with my calves that have kind of extended from my ankles. So it's rolling my glutes. It's rolling my calves. It's rolling my quads. I've actually had some issues with pain in my knees because of the way I'm not engaging certain muscles in my legs, which I can't remember the name of. But and then it's a lot of stretching around, especially hip flexors, especially glutes, but it's also hamstrings and calves. And then I've adopted sort of the figure four glute stretch to continue on to sort of, I can't remember, there's a name for it in yoga where you
Jim.
sort of hook your foot and then twist to the side. I find that is the single most effective thing for just taking tension out of my back. And that, and sometimes I'll actually, like I'll hear something plop in my back. And yeah, surprise, surprise. That's what I do on the cycling front. And the ones, if I only had like 3 minutes and I had to rush off, it would be hip flexors, it would be glutes, and it would be the sort of the spinal twist. Gord, your critique of what I'm doing?
No, all good. But don't take this advice that everyone should do that. It has to be pretty individualized. The spinal twist one is, we see more, the one that you love the most is the one we see most people hurt themselves doing.
Okay.
But it's not that you need to stop that. But yeah, so generally speaking, I guess, so if we go back to knowing that your back is flexion intolerant and cycling is a flexion thing, I guess the rehab arena would say, going back to the work of this really famous rehab specialist in Czechoslovakia, Vladimir Janda, came up with this formula that is actually pretty brilliant, where we now recognize the body compensates in really specific ways, and certain muscles have the tendency to become tight and other muscles have the tendency to become weak, and that results in very characteristic movement patterns, and which build over time to create injury. And so what we do is we start to structure routines around rolling and stretching the tight spots, followed by facilitating or strengthening the weak spots. And that's how you offset these muscle imbalances that build over time. So cycling, yeah, it's typically a quad dominant thing, but you want to try and release the tension in your quads and your hip flexors, and you want to try and build strength in your posterior chain, your glutes, and whatnot. I don't know if that helps you.
Yeah, no, that's good. Everyone, if you could try to put things into question and answer, because we've got both going right now, and so
Yeah.
well,
I did see one that says, is a chiro a person to see if you have osteoporosis, or do you see a physio? And yeah, so osteoporosis, so if you don't know, that's a weakening of the bones. So definitely there's treatments chiropractors can do to still be manual therapy, but you'd have to obviously know that there's underlying brittleness of bones so that you're not creating problems like fractures, for example. So you can still see a chiropractor if you have osteoporosis. Just make sure that they understand you have osteoporosis and that they're mitigating their treatment based on that. Physio, same thing. I mean, there's treatments physiotherapists do that they would need to understand you have an underlying bone issue. Otherwise, their treatments can result in injury as well. And I guess I would also say that the line between the two professions is really blurred. More progressive clinicians have recognized what treatments work and what treatments don't work for helping somebody with back problems. And whether you're a chiro or a physio, you tend to learn those treatments. So in my world, for example, chiropractors historically have been trained mostly on the manual therapies, the spinal manipulation or the adjustments, where we crack your back. But there's also mobilization techniques that are a lot more gentle. So it doesn't mean if you go to a chiro, they're just going to jump on you and create, cracking sounds in your back. But we also recognize that active care has to be built in. So a good way to figure out if you're in front of a reasonably minded practitioner is if they're introducing active care early in the treatment phase. So for example, I went back to school and got my postdoc fellowship in rehabilitation. So I'm almost like a blend between a chiro and a physio. And progressive friends of mine that are physiotherapists in town, they got their primary training was physio, which historically has been more in the teaching you things that you can do to help yourself. But then they went back to school recognizing that the manual therapies are really effective in helping people get out of pain. So there's a number of physios I know in Calgary that also adjust people's backs now, do spinal manipulation. So I don't know if that answers your question as far as who you see if you've got osteoporosis.
Okay, no, that's good. I think let's just finish off a couple on the chat side, and then we'll go to some questions on the question side. So I think one was a follow on to the cycling stuff. How does that differ from the sort of back pain management just for a day-to-day basis?
Yeah.
Again, I think it's very individual specific. For me personally, I find there's actually, so I ride and follow one of the programs I follow is called the Sufferfest, and they have some 15-minute. Yeah, doesn't that sounds awesome? Everyone's like, "Ooh, Sufferfest, write that down."
Get in the pain locker.
They do have some 15-minute yoga routines that I'm sure there's a ton of stuff available, especially during COVID. So there's a back specific sort of morning back 15-minute yoga routine that seems to work for me, that kind of gets everything warmed up and going well. I think over the years you try different things, you listen to what the different practitioners are that you work with, and you sort of incorporate what works. Is kind of where I've landed, right?
Yeah, there is a question there too about does it differ from day to day? No, I mean, Mike builds stuff in specifically for his cycling, but he has a flexion intolerant back. So he kind of has to do that if he sits at a computer too much, or if he's bent over chainsawing. And then what sort of tests or ways could you figure out if your back is flexion intolerant? I think you just take a look at your activities and what makes it feel worse. Like if you feel worse after you've been driving for extended periods, or if you're sitting on a couch watching, binging Netflix, or bending forward, doing whatever, then your back is probably flexion intolerant. And like I said, Mackenzie identified years and years ago, the vast majority of backs are flexion intolerant. It's just the way we're built. So if you were to have a guess or you weren't sure, I would probably bet your back is flexion intolerant. And a lot of that is also, most of our lifestyle is spent in flexion these days. You sit, you wake up in the morning, you sit down, you have your coffee, you do whatever, you hop in the vehicle, you sit, you drive to work, or you work from home. So you sit in front of a desk or a computer. Then at night you sit on the couch and you watch TV. And so your back is in flexion for hours, and it's not designed to do that.
Okay. What are your thoughts on strength training, specifically lifting weights? What is the correct way to do it? And does weight training help with improving back strength?
Strength training is good. But you have to, so here's, I just had one more question pop up based on what I was just talking about. Can you define flexion? That's anything where you're bending forward. So when you're sitting, you're bending forward, basically, if you can think about it that way. Or if you're standing and you bend forward, that's flexion. Extension is the opposite, when you bend backwards. Hopefully that defines it. Sorry, weightlifting? Is that what you're asking?
Yeah. So does
Yeah.
weight training improve back strength, and what's the correct way to do it?
Okay. So basically, the way I look at strength training is Gray Cook and Lee Burton created what's called the functional movement system, or the movement revolution, I guess. And they put in this really interesting thing that I love, and it's called the performance pyramid, which the base of the pyramid is functional movement, and that's based on that joint by joint model where there's a certain way we're supposed to move properly. And then the second layer of the pyramid is functional strength, and that would be your weightlifting, your strength training. And then the top of the pyramid is functional skill, and that's if you're doing a specific activity, you perform, drills or whatever to get better at that particular activity. Most of us ignore the bottom level of the pyramid, meaning we don't move very well and we just jump into the gym and do strength training. So then what you do is you start to build strength in faulty movement ways, and you reinforce those poor movement patterns, and you get quite strong in doing that. And that's where injuries happen. So I guess I would kind of qualify it to say, I love strength training. I think it's great, but I would make sure that you also build in or learn about the base of the pyramid and how to identify whether you're moving properly first. And if you're moving improperly, you build into your strength training routine some functional movement skill training, so that you, as you start to load up and lift weights, you reinforce the healthy movement patterns.
Yeah, and the thing that I would add, I mean, and I just had this happen recently where, I was having knee pain, um, and part of it was because I wasn't engaging some muscles on the right side of my body properly. I worked with a physio,
Yeah.
was given some exercises, and I don't know if this motivates anyone else, but by actually doing that, the knee pain went away, but also my performance improved because now I was actually engaging my muscles properly, and so I could actually ride faster. So but it was definitely a great example of I'd recruited the wrong muscles for so long that one of my muscles was actually atrophying, getting smaller, and I never even noticed until the physio showed me. Um,
Yeah. And I think all you have to do is, like, I've had the luxury of working with world-class athletes, right? With Team Canada and whatnot. And if you go to a gym where, you know, power lifters or Olympic lifters or anybody like that is training, it's amazing how much time they spend on technique as opposed to loading things up.
yeah,
And that just speaks to, making sure that they're moving properly so that they can lift those incredibly heavy weights.
yeah. Next question: is it best to come in for back analysis when the back is fine or when it flares up?
Um, I prefer people to come in when they're not, in a ton of pain, but if they're in pain, it doesn't preclude us identifying, what might have led to that pain. It just, oftentimes the focus of the treatment, if you're in a lot of pain, then we have to, you know, focus treatment and self-management strategies around getting your pain settled back out. And then the natural course of a care plan, once the pain is improved and you're doing well, then the emphasis starts to shift on to more of a functional rehab program and what we can get you doing, correcting the stuff that built up to become your back flare up. So either or, it doesn't really matter. If you came in to get assessed and you didn't have much in the way of pain, then there likely wouldn't be much in the way of passive care being recommended. It would be largely active care. Here's the stuff you can start working on. If you come in a lot of pain, then there might be more passive care needed to get your pain under control so that you can shift into more active care.
Yeah, and it's just to add to that, it's really interesting. So Gord's shown me some of the stuff that can be done from an assessment perspective for both cycling and for golf, when you're not in pain. And by doing certain assessment movements, it's shocking how how many deficiencies you can find, even though you think everything's good, and then you tip over while you're trying to do something, and you realize you're not engaging a muscle or you're not moving properly.
Yeah, I learned this long time ago by listening to, when I used to be the chiro for Alberta Ballet. They were so switched on with how their bodies moved that they would actually be able to pick up on movement problems and muscle activation problems that they were experiencing, and they weren't in pain, but they knew that's when they needed to come in and see me, because if they didn't address it, then their performance would deteriorate, but also it would build over time, and all of a sudden they get an injury. And that was pretty cool to witness.
Well,
You're not that aware yet, Mike, but
no.
we're working on it.
I think the word that's been used to describe me is oblivious about many things in life, so it probably also includes my back.
I would never say that to your face.
The people who aren't flexion intolerant, what are these people doing that keeps them this way? So I'm assuming what's being asked if is this, maybe it was flexion. So so for people where flexion is not the issue, maybe
Yeah.
maybe the person answering that question can clarify. But
Well, so yeah, I don't want to say every back is flexion intolerant. Like, to clarify this, keep in mind this was coming from a clinical point of view that Mackenzie identified by watching a bunch of patients. And certain back problems, once they're in pain, do recover better if we give them extension-based rehabilitation strategies. And so that would be a flexion intolerant back, because it gets better if we get you doing extension stuff. The other type of back problem that does better in recovery by giving you flexion stuff, typically, like a good example would be what we call spinal stenosis, where there's a buildup of arthritis in your spine, so that the holes that the nerves are trying to get through get narrowed down, and that ends up sending a bunch more pain down your legs. Those are typically back problems that would do better with flexion. These are the people that, if you get up and you start to walk, you get progressive pain going either in your back or down your legs. And as soon as you sit down, the pain starts to go away. And so these are the people that will tell you, my back or my legs are killing me as I'm walking. So when I'm in the grocery store, I have to lean on the grocery cart, or I sit down and the pain goes away. Those are people we would get flexing their spine to try and take the pinch off the nerves. So.
okay, and along that, one of the things we haven't talked about is we've got active treatment, we got passive treatment, and then where does surgical sort of treatment fall into this continuum? Like when's the time to, if things aren't getting better, when do you go talk to someone about surgical options? Or is that just too broad a question?
No, it's not a broad question. I'm not a surgeon, by the way. But
should we save that for the surgeon episode?
Yeah, let me call a surgeon. They're so easy to find these days. No, I mean, I've worked with spine surgeons for years. I guess, again, the change of thinking over time on where surgery can play a role in back pain. For the most part, if you haven't got what we call frank instability in your back, meaning the supporting structures of your back are no longer doing their job and your back is unstable, or for the most part, the predictor of back surgery and how it helps is how much leg pain do you have. Like if you've got a back problem, that is pinching the nerves that go down your leg, that is usually what would raise the interest of a surgeon. And then all the red flag stuff I talked about earlier, that's when we start talking about, does a surgeon need to get involved in a fairly timely fashion? For the most part, though, for the vast majority of people, surgery isn't necessary. The latest stats are saying surgery would only be effective for maybe 10% of back problems.
Okay. And what about, can you comment quickly on the right time for things like ice, for heat, anti-inflammatories, different pain meds, stuff like that?
Yeah, so generally speaking, again, our thinking on ice has changed. For example, we used to think of it as an anti-inflammatory, and we don't really think of it that way anymore. It's more of just an effective pain reliever. And as a rule of thumb, it should be thought of maybe in the early stages, what's called the acute phase. So let's say you were out chainsawing in the woods and you had an acute flare of your back, like you felt your back kind of go on you. That's ground zero. That would be a good time to start icing. And up to maybe 3 or 4 days later would sort of be a good frame for icing. And other than that, heat tends to help as well. But it's kind of that common sense thing. You try one, and if it feels great, then you keep doing that. But if it doesn't feel great, then you could switch to the other one. Either way, a good formula is you put it on there for a minimum of about 15 minutes, and then you take it off. You don't sit there with it on there for hours. You put it on for 15 minutes and then you take it off, and then you can repeat that, every couple hours if you really want to. NSAIDs are like over-the-counter non-steroidal anti-inflammatories. So these are the Advils, the Tylenols, that kind of stuff. Technically, I'm not really supposed to give advice on that stuff. It's outside of our scope of practice. But so a pharmacist or a family doc might be a better resource. But they are one of the recognized effective treatments, at least in the short term or the early phases of a back pain flare. There's really only a couple of things that have been demonstrated to help people if you have a flare up, and that's one of them. And the other one is manual therapy, the manipulations. Other than that, most of the passive care treatments don't have a lot of good research to show that they're that effective.
Okay. So I think that's a great place to end. I think we've answered all the questions, and it is now 12:59. So I'd just like to thank everyone once again for showing up today and adding the questions to the comments box. It's always great because it helps make things more practical for other people. And a huge thank you to Dr. Gord McMorland for sharing an hour of his time today. And hopefully this will be beneficial to not just the people who attended, but the people who watch the webinar later or listen to the podcast. So thank you, Gord.
Yeah, thanks, Mike. That was great. I hope people found some value in it, and I resisted the urge to tease you more than I normally do.
I appreciate that. Thanks, everyone, and have a great rest of your day.